What if I told you that the blood test your doctor has been ordering for the last 30 years, the one that measures your total cholesterol, is one of the weakest predictors of whether you're actually going to have a heart attack? I know that sounds shocking, especially when we've spent decades being told to eat less fat and keep our cholesterol low. But here's the truth that most people never hear in a 10-minute doctor's appointment. Half of all people who suffer a heart attack have completely normal cholesterol levels. Half. That means millions of people every single year walk out of their doctor's office feeling reassured, believing their heart is fine, only to end up in the emergency room weeks or months later. Today I'm going to change that for you. I'm going to walk you through 3 specific blood tests that cardiologists, the specialists who actually treat heart disease every day, rely on to get a far more accurate picture of your cardiovascular risk. These aren't obscure experimental tests. They're available at most labs, they're often covered by insurance, and they could genuinely save your life. Stay with me, because the information in this video is something I wish every single one of my patients had known years earlier. Let's start by understanding why cholesterol became the dominant metric in the first place, because the story behind it actually helps explain its limitations. Back in the 1960s and 70s, large population studies began to show a correlation between high total cholesterol and increased cardiovascular events. This was a groundbreaking discovery at the time, and it led to decades of dietary guidelines, statin medications, and routine cholesterol panels being ordered at virtually every annual physical. The science was real, but it was incomplete. What those early studies didn't capture was the complexity of how cholesterol actually behaves inside your arteries. Cholesterol itself isn't inherently dangerous. In fact, your body needs it to make hormones, vitamin D, and cell membranes. The real danger lies in what carries it through your bloodstream, how inflamed your arteries are, and whether your body can clear it efficiently. Total cholesterol doesn't tell you any of that. It's a bit like trying to predict whether a city will have a car accident by counting the total number of cars, without knowing the road conditions, the speed limits, whether the drivers are impaired, or how many of those cars have faulty brakes. The number alone is nearly meaningless without context. So let's get into what actually matters. The first blood test you need to know about is called Lipoprotein A, written as LPA and pronounced LP(a). This is arguably one of the most underdiagnosed cardiovascular risk factors in medicine today, and the reason it's so important is that it is almost entirely determined by your genetics, meaning diet, exercise, and lifestyle changes will do virtually nothing to lower it. This is both sobering and critically important because it means that if you have elevated LPA and you don't know about it, no amount of healthy eating will protect you the way you think it will. LPA is a specific type of LDL particle, what most people know as bad cholesterol, but it's coated with an additional protein called apolipoprotein A, which makes it far more dangerous than regular LDL. This extra protein makes LPA stickier, meaning it adheres more easily to the walls of your arteries. It also promotes the formation of blood clots, and it actively interferes with your body's natural ability to dissolve those clots once they form. The combination of these 3 properties, arterial stickiness, clot promotion, and clot persistence, makes elevated LPA one of the most aggressive drivers of early heart disease and stroke. Studies suggest that roughly 1 in 5 people, that's approximately 1.4 billion people worldwide, carry elevated levels of LPA without knowing it. Current guidelines from the European Society of Cardiology recommend that every person have their LPA measured at least once in their lifetime. The American Heart Association is moving in the same direction, so why doesn't your regular doctor order it? Largely because it's not yet part of the standard lipid panel, and because until recently there weren't approved targeted treatments for it. But knowing your number is enormously valuable because it changes how aggressively your doctor should manage every other risk factor you have. If your LPA is elevated, your doctor needs to be far more aggressive about controlling your blood pressure, your blood sugar, your regular LDL, and your inflammatory markers. The target for LPA is generally below 50 milligrams per deciliter or below 75 nanomoles per liter, depending on which units your lab uses. If your number comes back elevated, don't panic, but do have a serious conversation with your doctor about a more proactive management plan. Now let's talk about the second test, and this one surprises people even more because it measures something most people don't associate with the heart at all. It measures inflammation. The test is called high-sensitivity C-reactive protein, or hs-CRP. Regular CRP has been used in medicine for decades to detect acute infections and inflammatory flares, like when someone has pneumonia or a flare-up of rheumatoid arthritis. But the high-sensitivity version of this test detects much lower, chronic levels of inflammation, the kind that simmers silently in your arteries for years before culminating in a heart attack or stroke. The concept of inflammation as a driver of cardiovascular disease was somewhat controversial when it was first proposed, but it has now been confirmed by some of the most important clinical trials in cardiology history. One of the landmark studies, called the Jupiter trial, published in the New England Journal of Medicine, enrolled nearly 18,000 people who had normal LDL cholesterol but elevated hs-CRP. The study found that treating these individuals with a statin, despite their normal cholesterol, dramatically reduced their rates of heart attack, stroke, and cardiovascular death. This was a paradigm-shifting finding because it showed that inflammation, independent of cholesterol, is a major driver of heart attacks. Think of your arteries like the walls of a pipe. LDL cholesterol can deposit inside those walls, forming plaques. But what turns a stable plaque into a deadly one, what causes it to rupture and trigger a sudden heart attack, is inflammation. hs-CRP is a direct window into that inflammatory process, and hs-CRP below 1 mg per litre is considered low risk. Between 1 and 3 is intermediate risk. Above 3 is high risk for cardiovascular events. Now there's an important nuance here. hs-CRP can be temporarily elevated by infections, recent illness, or inflammatory conditions like autoimmune disease. So if your result is high, your doctor will want to repeat the test when you're feeling well to confirm whether this is truly chronic. Baseline inflammation. What causes chronically elevated hs-CRP? Factors include obesity, especially abdominal fat, which is metabolically active tissue that constantly secretes inflammatory molecules, chronic stress, poor sleep, smoking, a diet high in processed foods and refined sugars, insulin resistance, and gum disease. Yes, gum disease have all been shown to raise hs-CRP. The good news here is that unlike LPA, you have real power to lower hs-CRP. Regular aerobic exercise, weight loss, a Mediterranean-style diet rich in vegetables, olive oil, fatty fish and nuts, improved sleep quality, stress management, and treating underlying inflammation can all bring this number down significantly. The third blood test is one that sits at the intersection of metabolism and cardiovascular disease, and it's called ApoB, short for apolipoprotein B. If there is one single lab value that many cardiologists are now advocating should replace or at least supplement the standard lipid panel, it is ApoB. Here's the reason why, explained as simply as possible. Your standard cholesterol panel measures the amount of cholesterol floating inside lipoproteins, the protein packages that transport fats through your blood. But what actually damages your arterial walls is not the cholesterol sitting inside those packages, it's the packages themselves burrowing into your arterial lining. Every single LDL particle, every VLDL particle, every IDL particle, all of the potentially atherogenic or plaque-causing particles in your blood, each carries exactly one ApoB protein on its surface. That means ApoB directly counts the number of dangerous particles in your bloodstream. This is a crucial distinction. Consider two people with identical LDL cholesterol levels of 120 mg per deciliter. Person A has large fluffy LDL particles and person B has small dense LDL particles. They have the same total LDL cholesterol on paper, but person B might have 3 or 4 times as many individual LDL particles because the same amount of cholesterol is packed into many more smaller packages. Person B's ApoB would be significantly elevated even though their LDL cholesterol looks normal. And it's the particle count that predicts risk. Multiple large studies, including the famous Amoris study, have shown that ApoB is a stronger predictor of cardiovascular events than LDL cholesterol, total cholesterol, and even the traditional cholesterol ratios. Optimal ApoB is generally considered to be below 90 mg per deciliter for average risk individuals. and below 70 or even 65 for very high-risk patients, for those with established heart disease or diabetes. What drives up ApoB? Insulin resistance and metabolic dysfunction are among the biggest culprits. People with type 2 diabetes or pre-diabetes, people with metabolic syndrome, and people who eat diets very high in refined carbohydrates and sugars tend to produce more of these small, dense, ApoB-rich particles. This is why some people on a high carbohydrate diet can have relatively normal LDL cholesterol, but sky-high particle counts and ApoB levels. Conversely, you can lower ApoB through the same lifestyle interventions that improve metabolic health overall, reducing refined carbohydrates and added sugars, losing excess weight, exercising regularly, and in many cases through medications like statins, which lower ApoB very effectively. Now, I want to tie these three tests together for you because the real power comes from understanding how they interact. Think of it this way. ApoB tells you how many dangerous vehicles are on the road. LPA tells you whether some of those vehicles have faulty, over-aggressive brakes that make them likely to crash and stick. And hs-CRP tells you how dry the tinder is, how inflamed and vulnerable your arterial walls are to being ignited by one of those crashes. A person with normal cholesterol but elevated ApoB, elevated LPA, and elevated hs-CRP faces a far higher lifetime risk of heart attack than someone with high cholesterol but normal levels across all three of these markers. This is why cardiologists who specialize in preventive medicine often call the standard cholesterol panel insufficient on its own, not because cholesterol doesn't matter, but because the picture it provides is incomplete. If you are somebody with a family history of early heart disease, and by early, I mean a first-degree relative like a parent or sibling who had a heart attack before age 55 in men or 65 in women, getting these three tests done should be considered non-negotiable. If you are someone with diabetes or prediabetes, metabolic syndrome, obesity, hypertension, or a history of smoking, the same applies. And honestly, even if you have none of those risk factors, knowing your LPA at least once in your adult life is something I would advocate for universally, given how common it is and how genetic it is. When you go to your doctor to ask for these tests, here's exactly how to frame the conversation. Ask specifically for an LPA, a high-sensitivity CRP, and an ApoB. These are standard laboratory tests. They are not experimental. LPA and ApoB are covered by most insurance plans, especially when cardiovascular risk is a concern, and hs-CRP is inexpensive and widely available. If your doctor is unfamiliar with their relevance, you might ask for a referral to a preventive cardiologist who will be very familiar with all three. Prevention is always better than treatment. A heart attack doesn't give you a warning. It doesn't send you a letter in advance saying it's coming. It happens fast, it's often devastating, and it's frequently the first sign that anything was wrong at all. But the biological processes that lead to that moment build up over years, and during those years these blood tests can see what's coming long before symptoms ever appear. That window of time is your opportunity to intervene, to change the trajectory, and to add years of healthy, active life. Remember this, 3 tests, 3 crucial windows into your cardiovascular risk. LPA for your genetic particle danger, hs-CRP for your arterial inflammation, and ApoB for your true particle burden. Together they paint a picture of your heart health that total cholesterol simply cannot. Talk to your doctor, ask for these tests by name, and take the results seriously. If you found this information valuable and you feel like it gave you something genuinely useful that you haven't heard before, please take a second to subscribe to this channel and give this video a like. It helps more people find this content who genuinely need it. And I'd love to hear from you in the comments. Did you already know about these tests, or was this new information? And what topic would you like me to cover next? Your suggestions actually shape what I make, so drop them down below. I read every single one.